Choledocholithiasis. Etiology, pathophysiology, and pathology. There are three main types of stone: cholesterol, black pigment, occur in chronic hemolytic disease, and brown pigment stones, associated with infections in the biliary tree. They are almost always found in the gallbladder, and if they escape are usually confined to the extrahepatic biliary tree. Intrahepatic biliary stones are rare, but seen more frequently in the Far East. Epidemiology. Overall prevalence is 10%. Incidence increases with age and is twice as high in women as in men. Clinical presentation. Common. Asymptomatic, incidental finding on imaging. Cholestatic liver function tests, raised alkaline phosphatase, ALP, and gamma-glutamyltransferase, GGT. Indigestion, particularly exacerbated by fatty foods. Biliary colic. Acute cholecystitis, fever, right upper quadrant pain and tenderness, jaundice. Ascending cholangitis, high fever, rigors, jaundice, Thierko's triad. Acute pancreatitis. Uncommon. Obstructive jaundice without symptoms. Gallstone ileus. NB. Elderly patients with cholangitis and secondary gram-negative septicemia commonly present with nonspecific symptoms, e.g. off legs. Physical signs. Common. There may be no signs, although jaundice may be present with right upper quadrant tenderness. In acute cholecystitis, look for Murphy's sign. Rare. The presence of splenomegaly suggests hemolytic anemia with secondary pigmented common bile duct, CBD, stones. Investigations. Blood tests. FBC and reticulocyte count. An elevated white cell count occurs with cholangitis. Macrocytic anemia and elevated reticulocyte count suggests hemolysis. Liver biochemistry. Classically elevated bilirubin and ALP and GGT, rarely in acute biliary obstruction. Aspartate transaminase, AST, and alanine transaminase, ALT, may be greater than 1000 U/L. Ultrasound. The preferred investigation for detecting stones in the gallbladder, but remember that the sensitivity for stones in the CBD is only 70% and the only sign may be duct dilatation. NB. The CBD may not be dilated on ultrasound in incomplete biliary obstruction. Endoscopic retrograde cholangiopancreatography. Endoscopic retrograde cholangiopancreatography, ERCP, can both confirm that a stone is causing biliary obstruction, Fig 38, and be employed therapeutically to remove stones. It will also identify any distal CBD stricture, benign or malignant, that may have resulted in proximal stone formation. However, ERCP does carry significant risks, and so magnetic resonance cholangiopancreatography, MRCP, should be considered first, if available, in patients who do not require immediate or urgent therapeutic intervention or if there is diagnostic uncertainty. Magnetic resonance cholangiopancreatography. This is a non-invasive method of imaging the CBD and pancreatic duct without the need for contrast and therefore has far fewer risks than ERCP. It can be used to detect CBD stones and strictures, see Fig 24, and consequently ERCP should be considered a therapeutic procedure and should not be performed solely for diagnosis in centers where MRCP is available. Differential diagnosis. Other causes of biliary obstruction such as tumor or congenital abnormalities such as Choledocholithiasis cysts. Treatment. Emergency. Emergency early ERCP, within 72 hours, with removal of CBD stones is indicated in patients with acute pancreatitis associated with obstructive jaundice. An alternative approach is laparoscopic exploration of the CBD with stone extraction and cholecystectomy. This may have less morbidity and mortality than ERCP but is not widely available. Short-term endoscopic removal of stones. Asphincterotomy or balloon sphincteroplasty, cutting or dilating the sphincter of Oddi with a balloon, is performed and the CBD trawled with either a balloon or basket to remove the stones. The sphincterotomy allows any retained material to pass. There is a significant risk of acute pancreatitis, bleeding or duodenal perforation, with a 0.51% mortality. Larger stones may require crushing with a mechanical lithotripter or, alternatively, a stent can be inserted to allow bile drainage and a further attempt at removal at a later date. Stenting often causes the stones to shrink over time. Occasionally a nasobiliary drain is required to provide temporary biliary decompression. Long-term interval laparoscopic cholecystectomy in patients for whom surgery is appropriate. In those who are not surgical candidates, and when it is not possible to remove large stones endoscopically, a CBD stent can be left in the bile duct to provide adequate biliary drainage. Fig 39. This will usually block within 3-12 months and hence most patients are brought back for repeat ERCP and stent exchange every 3-6 months. Complications. Cholangitis and secondary septicemia are common. Prolonged asymptomatic biliary obstruction can rarely lead to secondary biliary cirrhosis. Prognosis. Good if CBD stones are removed. Disease associations. Hemolytic anemia, e.g. sickle cell, or spherocytosis leading to pigmented large or intrahepatic stones. Ileal disease and resection, which interrupts enterohepatic circulation of bile acids. Clonorchis infection, associated with intrahepatic stones, but exceedingly rare in the UK. Total parenteral nutrition, associated with sludge and stones.